La siguiente presentación es sobre el futuro del tratamiento antirretroviral y tenemos la inmensa suerte de tener aquí al doctor Anton POZNIAK, que es Consultant Physician and Honorary Senior Lecturer y director de HIV Services en the Chelsea and Westminster Hospital, NHS Foundation Trust and Imperial College London. Él lleva viendo pacientes VIH desde 1983. Tiene mucha experiencia también con infección VIH y tuberculosis. Él trabajó en Zimbabue durante bastante tiempo. Es un miembro vitalicio de la Asociación Británica de VIH. Es el tesorero del IAS. Ha trabajado en múltiples comités, en múltiples guías de expertos. Ha publicado mucho sobre tratamiento antirretroviral. Os recomiendo, si no lo habéis leído, su editorial sobre las guías de GESIDA en enfermedades infecciosas y microbiología clínica, Observing the Revolution. Una gran editorial, y tenemos una fortuna para hablar. Que yo conozca, solo tiene 2 defectos. Le gustan los partidos de cricket que duran 3 días y cree que la cerveza negra debe ser bebida por los seres humanos. Cuando quieras, Anton.
Thank you very much for that introduction. That was wonderful. I'd like to thank the organisers for asking me to give this talk. I've got very many friends, close friends in Spain in the HIV community, and I'd like to thank you all for inviting me to your 20th birthday party, and I think it's a wonderful achievement that you're keeping this society at such a high level of scientific expertise. So I'm going to talk about the future of antiretroviral therapy. Well, a few things I'm going to comment on, because we can't talk about everything, about when to start. There's no question about it. Because it's World AIDS Day today, I'm going to talk a little on cascades of care, about the guidelines and how all the experts are in disagreement, and a little bit about how we must think about trial design for the future of HIV therapy. Something about existing drugs. Like the Roman Empire, some of them have declined and fallen, and some of the Roman guards have now come up to fame, and we'll see how that is. A bit like my football team belongs to the decline and fall. So, and finally, a bit treatment switch. And I can't leave the future without talking about money and politics, which is all close to all of our hearts. So more is less. I just wanted to, before I talk about the start, ask you all, just think, no voting, just think internally. If there was a policy here where you could take aspirin, or you didn't need to take aspirin, you've got a choice to take it or not, and it gives you a difference in protection of 2% over 10 years, would you take it? Would you take the aspirin for that level of protection? Just a thought. So the START study, thank goodness we can all agree. It's been many years. I've been to so many meetings where they said, start now, don't start now, do this, delay. And you know, British HIV Association and EACS had this thing about waiting to 350. But actually in Britain, there's only about 5,000 or 6,000 people who haven't started, who we should have started if we'd have had the START study earlier. So it isn't that many. We've been starting people early a long time. But this is great, all green, all fine, we all agree. And you can see here that the difference, 4.1, 1.8%, and the DSMB, what they looked at, they said, look at this, 57% reduction in events. It's reached a fixed point at which we have to stop the study. Quite right, and quite right that what they said was a combination antiretroviral therapy should be recommended for all HIV-positive people at any CD4 count. And it just shows, after 500 CD4s, it's not a very useful marker for much at all. But hang on, stop a moment instead of starting. The absolute risk of deferring ART was small, 3.7 versus 1.8 over 3 years of follow-up. There's a small difference, but it was important because it was related to cancers and tuberculosis. And when I heard this, I phoned the British HIV Association and sent them an email saying, we have to change the guidance. We have to say everyone must start treatment. And we thought about it too. So we said, yes, everyone should start treatment, but we're doctors. And we know that patients will come and say, I don't want to. And even though you give them every argument, you discuss the START trial, they still say, hang on a minute, I might want to wait. And therefore, we have to give them the data in some reasonable way at which if they want to wait, we can tell them what the risks are. Because if you tell a patient who's not ready to take treatment, you have to start, you might give him the drugs, he'll go home, and I guarantee most of them won't take them or will take them badly. So it's better to work on them over several months, over a year or so, telling them every time what the risk is of not starting therapy. So start's great. Everyone should start, but patients are patients, and we have to be a little bit flexible with them. Now, it's World AIDS Day, so I thought I'd talk about the big picture. So this is what UNAIDS wants everybody to do by the year 2020, so that is the future. They want, out of 36.9 million people in the year infected today, they want 90% of those people diagnosed, 90% of that 90% to be on antiretroviral therapy, and 90% of that 90% to be suppressed. That's a total suppression rate of 73%. So there we go. Those are the targets that they have. What's the reality today? Well, only about 53% of people have had a diagnosis. And if you look to your own figures, and I look to mine in my country, we still haven't diagnosed 90% of people. On art, 15 million. That's wonderful, but that's only 41% of the world. And viral suppressed, 32%. We still got quite a long way to go in the next 4 and a bit years, 5 years, okay, for us to achieve this. And one of the reasons we won't do it in every country, and I try to be a realist, is this. How do we achieve 90-90-90 globally, in spite of all the hype and everything else, when you can see that although in 74 countries there are laws in place protecting people, right, protecting key populations, there are 76 countries in the world where same-sex practices, being gay, is criminalized. So then you've got to say to somebody, I'd like to give you antiviral treatment. You might identify them as being same-sex. They could go to jail because you've given them antiviral therapy. There are also, in 7 countries in the world, they could be punished by death. So you imagine being identified as someone who's HIV positive, who might be gay, or might be a sex worker, or might be a drug user here. And you can see that these, in blue, that percentage of countries whose laws, regulations, or policies can hinder service provision for sex workers, MSN, and people who inject drugs. There's still a problem globally on World AIDS Day with us having to deal with the politics of this. So I'm going to then say, 90-90-90, please, could somebody volunteer to go to Afghanistan for the next 5 years, please, to get them into 90-90-90. And I'm not joking here. There are places like Yemen and the places like Afghanistan, go to Syria to try and do this. So I'm realistic. It's going to be very difficult to do these things. And even in major countries, you can see that actually nobody's reached it in Europe yet, except I do have data from Sweden, and they have. They're probably the first country. They've got 6,500 people infected. It's not too difficult to get to 90-90-90 in an industrial country like that. But the rest of us have a long way to go. I just might note the United States is rather a way to go more than anyone else. And what about the UK, right? The UK is third in the world for the 90-90-90, third in the world. Yet our epidemic has been flat. We are not going down in terms of numbers of people diagnosed. We need PrEP, we need other strategies, we need more testing. Treating people doesn't always have the impact you want on epidemics. So, I want to change now and look at the future of treatment guidelines. The problem of what to start, it's really a problem of data interpretation. So here's all the trials. I want you to go home tonight, don't go to dinner, don't enjoy yourself, but read them all. Read every trial in detail, and tomorrow write the guidelines that you would like. And that's what guidelines panels do. They sit down and they look at all the data and they do that. Now you'd expect that if you've got guideline panels around the world doing this, you come to more or less the same conclusion. You can see in yellow, they'll agree. In black, they don't agree. So you can see here that there are some things like efavirenz, all gone. We all agree. Darunavir, you guys don't. DHSS and BEVA do. Atazanavir, DHSS and Gesida don't. BEVA say yes. Stribild, alternative for you. And these three integrases are all fine. So it's really difficult to find one guideline that agrees with another guideline around the world. And when you get EACS is a bit like DHSS, in fact. So you can agree to disagree. Are there 4 or are there 3? Looking at the same data. So we really have to start thinking about what we're going to do with guidelines in the future. And the future of antiviral therapy, for me, is dependent on good quality research data. So should we think about changing the way that we design trials? Should we have superiority trials for HIV? Should we remain with the non-inferiority, or what the ACTG do with equivalence? Now, is the new treatment better than the controlled treatment I'm using now? That is a superiority trial. Is it better? Should we move to that? Rather than, if it's not better, is it sort of the same that I'm using now, right? That's non-inferiority. Or equivalence. Can I use the new treatment and the controlled treatment interchangeably? And it's quite difficult philosophically to get our heads around what these things mean. So, non-inferiority. You require a high-quality trial. I'm not saying everyone I showed was high quality. And if you execute the trial badly, you'll favor non-inferiority. So go and do it in a place they're not used to doing trials, where people don't take the data properly, or people drop out, and all sorts of things happen. Also, to have a good non-inferiority trial, you need a strong control. So what did we do? In the early days, everything was against nalfinavir. Then the next lot of trials, everything was against Kaletra, really strong controls. Now everybody says, let's put it up against efavirenz. So you can see they favor non-inferiority. And the other thing is, you say, well, if it's 12% worse, it's non-inferior. Well, that's not good enough. 12% worse is, in many people's book, is inferior, and it should be moved up to something like 8%. Some statisticians say if it's not 6% worse, if it's more than that, it's no good. Okay, so we've got to think about clinical trials. And the problem now in HIV is all the drugs work really well if you take them. If you take them, you get 90% efficacy rates. Or more. And you can see here that maybe all the trials we're looking at, they're very dependent on adverse events and discontinuations because of these. And even these are low. So how do we design trials when we've got very good efficacy and very few adverse events? What sort of trial should we design to inform the guidelines committees? Well, I think open label trials from now on should be really downgraded, because if they're open label and you know what you're on, first of all, you select the right guy. You say, yeah, you'll do really well on this, if you take it. Next thing is there's a big impact. If I know I'm on something and I wanted to be on the other drug in the other arm, I might stop. I might stop and go, I don't want to be in it anymore. I've taken it for a couple of weeks. I don't want it. And also, when they report the primary endpoint at 48 weeks, everybody goes, that was better than the one I'm on, I'll come off it. Yet, we all know that sometimes we get surprises when we follow people through for 96 weeks and beyond. So it really is a problem, open label studies. Cohorts. Now, I'm going to be a bit of a heretic. Do we really need cohorts anymore, or the way that they're designed at the moment? Should we trust them? Let me just show you this. Abacavir and cardiovascular risk. Cohort, yes. Clinical trials, no risk. Efavirenz and suicide, cohorts, no risk. Trials, risk. NA Accord said if you start antiviral early, there'll be a big impact on mortality. START trial didn't show that. So do we need cohorts to tell us that tenofovir can cause renal dysfunction? I don't think so. Yet people keep collecting all this and saying, if you're on tenofovir for more than 10 years, your chance of getting renal dysfunction is X. Okay, so. And the problem is cohorts is there's a lot of channeling bias, they don't collect all the data, there's a load of lead time, and it's whether they're closed cohorts or open, and they keep refreshing them. Let's add a few more people to this cohort, which may be a biased population. So we should stick with trials. We should stick with double-blinded trials, and for those of you who don't know, a triple-blinded trial is when the statisticians are blinded as well to the data that we receive. But we have a problem. We have even more a problem. because the trials now are recruiting young MSMs with high CD4 and a low viral load. So not only do we have highly efficacious drugs that don't have side effects, but we're recruiting the best candidates from the best centers. How are we going to differentiate where that regime A is better than regime B? Okay? The best thing is to make regime B efavirenz and look for neuropsychiatric side effects, and then you're going to win. Okay. And you know, this will be even more so after start, because we'll now have trials starting at any CD4, you know, and we'll have a big cohort. The median starting CD4 was 900. Okay, it's going to be very difficult to find any issues between the groups. So, the future again. Let me just talk about some of the drugs. Do we need nucleosides? And there are so many discussions about this. If we could get rid of abacavir tomorrow and substitute with something else, we'd probably all say great. We don't need to do an HLA test. We don't have to worry about cardiovascular risk. We don't have to worry about viral load. If we can get rid of tenofovir tomorrow, we'd all say yes, because we don't have to worry about renal and bone. And in fact, for tenofovir, we now have TAF with less bone mineral, and you can use it down to an EGFR of 30. So the tenofovir issue is sort of getting solved, not the abacavir issue. Can we do it without nukes completely? Just throw them away and let's use another class. You can see here the big black diamond. When you try and use a PI and an integrase together, it doesn't work as well as when you try and use those drugs with nukes. There's something magical in the nukes that is better. Who would ever expect that? And when we did the NEAT trial, it was a total surprise that that would happen. Wasn't as good. Maraviroc, well, okay, you were not too surprised that if you give a PI Maraviroc, it doesn't work as well, but it should, and it didn't. Okay, so we have had a problem. So what can you do? You can limit nucleosides, nuke-limiting strategies where you take away some of the drugs. Now, for me, less drugs sounds good. I don't have to pay as much. There's less toxicity. There's less prescriptions to write out in a busy clinic. All looks good. So where are they going? Well, this is, and Pedro Khan's going to be here, I think, tomorrow. He did this study called Gardel. And what he said was, if we give Kaletra plus 2 nukes, or we give Kaletra with just 3TC, what's the difference in naive patients? The difference is no difference. It looked really good. In fact, there was less side effects when you didn't give the other nucleoside. So this is dual therapy with a boosted PI. The problem is who's going to start patients on a boosted PI tomorrow if you've got other drugs you can give the patient? So what else can you do? Well, let's not give the boosted PI. Let's treat an integrase like it's a boosted PI and give 2 drugs, an integrase and 3TC. And that's what Pedro's done in the PADDLE study. For me, PADDLE doesn't have a great name. You know, it's a bit slow. And if you drop it in the water, you're lost. So I think they should change the name from PADDLE to something different. Anyway, what he did, he gave dolutegravir and 3TC in treatment-naive patients. And he was extremely careful, because we have to be. This is very experimental, really, really experimental. So he gave this in 2 cohorts of 10 people, only 20 people. But the results are very interesting. He gave it to people with low viral load, so low risk. So I think this is good. You're going to do something very experimental. You take it to your IRB, you get consent, you really tell the patients there's a risk, and you do it stage by stage. Anyway, look at this. This is a very complex diagram, but it's not. Yellow means you're undetectable. And when you look at week 8, everybody in this study was undetectable. And all the other colors mean your viral load's going down. And look at this, baseline. Some of them were screened. They're all screened below 100,000. 4 of them, had more than 100,000 when the next viral load at the time, the day they took the first pill was. And it's interestingly, those guys took maybe a bit longer to go down, but they all got undetectable. Now remember, before we all start doing it to our patients, it's 20 people, highly observed, highly motivated, really talked to, okay? So let them do a bigger trial first before we all do this in our clinics. We've got lots of drugs, so we know how they work, and everybody's happy with them. This is fantastic, but it's experimental. So, what else could you do? No nukes and long-acting injectables are on their way, and this is carbotegravir and rilpivirine. You can't see a nucleoside here. and they've got some very good data about undetectability. The issue is that what they want to do is you go undetectable on this, and then they give you injections monthly. Now the trouble is it's 4 mils. Has anyone ever had 4 mils stuck in their backside? I don't recommend it, okay? So that's the problem, I think. I think a lot of people have said they had to take the next day off work after having the injection because they were sore and they couldn't sit at their desk. Maybe they should stand up, but anyway, that's not for me to say. So integrases have been on the rise, as you know, and is this the end of ephedrins and the end of PIs in the whole future of HIV, and they'll be just used in niche groups? Well, raltegravir was superior to atripla, dolutegravir was superior to atripla and darunavir, and elvitegravir was superior to atazanavir in the WAVE study. It's looking good for the integrases in terms of putting them up, and when you look at your guidelines, you agree with all of this, and you've put them at the very, very front. And you can see here that raltegravir, when you looked at everything, not just virological, but all the other outputs, that it was better than the PIs. And again, with dolutegravir versus darunavir superiority. So the integrases have really established themselves in a very rapid period of time. We've gone from raltegravir and some issues with it, BD and everything else, to suddenly everybody loving integrases. But could we save ephedrins? So small is beautiful, and we might do, and in fact, we could possibly save ephedrins by reducing the dose. It worked just as well, and there were more discontinuations on the high dose ephedrins versus the low dose. And in fact, you know, they're going to start manufacturing pills with low dose ephedrins in, and WHO have said that they're going to approve low dose ephedrins as an alternative. So, you know, if you've got no money and it's absolutely cheap, that may be a way to go, rather than using the more expensive drugs. Are all pills going to be single pills in the future? Are all regimens we're going to take? They're almost there now. We have NNRTI, integrase, and PI-based single pills. The PI-based one's on its way. Everybody wants to get single pills, and I can understand why. It's convenient and it's easy, etc. But single pills have a problem. You can't adjust the dose of any of them inside the single pill. You can't reduce the tenofovir, and you can't reduce the 3-TC. Some pills might be a bit big to make. Why don't we just put them in a blister pack? Might be cheap. 3 generics in a blister pack or a single pill. And you just push the 3 out and you eat them all at once. Half-lives, if you stop, well, that's the same even if you take more than 1 pill. And if you have a 184V mutation, it's pretty difficult to think of single pills that will work with that. Where's the data that single pills make a big difference? And they're patented, so they're more expensive. And it may be that if you put people on a single pill, that later on the funders will say, you've got to switch them off, which will be disturbing to the patients. So, just before I finish, a little bit about switch strategies. Switch strategies for virally suppressed. We printed this publication and we really said that in switches, for people who are absolutely stable, you should have a reason to switch. And there was a lot of contention over this. I'm looking at my chairman here, but this is a belief. It's not, you know, and I'm putting here about the future. Now, here's a switch study, and I'm just showing it as an example that you can cause problems for some patients, even though with the best intent, you're trying to switch them to something that you think might be easier to take. So these people were all very stable and very happy on what they were on, and they switched to dolutegravir, bacavir, 3-TC single pill. It worked very well. Look, you know, you can see the protocol was fine, and here the ITT was slightly, the point estimate was better for the drugs that you started with. But the problem was that the only people to have serious adverse events were the ones that were switched to the new drug. And we have to remember that when we do switch people to a new regimen, there are problems sometimes with doing that. You have to keep that in mind, and the patient may have issues that they want to switch back. So not always is the rainbow there that's beautiful with gold at the end of it to take. Sometimes you can cause problems. Now, don't do this at home. These are 2 switch studies from again, suppressed patients who switched to dolutegravir monotherapy. And you know, there's a big tradition of switching to PI monotherapy when you're stable, and these were that. Now, the first study was, there was really good reasons to switch. They had a lot of problems, and in fact, you had to have 2 reasons to switch, which I think if you're going to do an experimental study, for me, that's very good. You know, there's lots of problems on your current therapy, and you're given an advantage to switch to something that'll be simpler and remove those problems. But there was another separate study of switch, where people were just switched in a clinic as clinical practice, okay? And although they said 89% of patients maintain virological suppression, 3 people had virological failure. Now let me just show you, and in this study only 1 person did. Now let me show you what happens if you get virological failure. Relatively low HIV levels, right, RNA levels. You can see here that this first patient did get a mutation, looking at the DNA. This person has got a resistant mutation to elvategravir and raltegravir, elvategravir, and this one, dolutegravir, elvategravir, and raltegravir. And the story is that all of these people had had an integrase before. My message is, number 1, this should be a clinical trial, right? They shouldn't be clinical practice. Number 2, and the first one was, it was a study. Number 2 is, if anyone's had an integrase before and you don't know that they've absolutely been undetectable all the time on that integrase, don't switch them to integrase monotherapy. We have to be very careful with it. And what does the future hold? Well, there's this Australian paper which basically says all the treatments will run out in 45 years' time. Well, I'll be dead by then, so do I worry? Yes, I do, because some patients of mine will still be alive in 45 years, so I have to worry. And it says that 10% of people will use up their drugs in 25 years. So what about the pipeline? Now, I hope you can't read this. I hope you can't, because the pipeline is not very much. There aren't that many drugs. It's not so exciting. There are a few things coming along. There's a new integrase, there's a new NNRTI, there's an attachment inhibitor, etc. But the pipeline is quite sparse. So we have to now keep calm and do more with less. And finally, this is the economics. The current investment in AIDS is $22 billion a year, and it needs to be increased. So we're up to $31 billion US dollars in 2020. This is for world AIDS. And then, because lots of people would be treated and there would be less cost in terms of diagnosing people, in people having AIDS, and the cost of drugs comes down, the cost would decline to $29.3 billion. And the economic, social benefit of keeping people alive so they can go to work and be productive is being estimated as $3.2 trillion. Now, if I go to the banker and I say, hey, do you want to spend $29 billion and get back $3.2 trillion? He'll go, he won't even think for a second. Yes, now. This is the investment we have to put into people, not into the bank. So, and in resource-rich countries, what will be the impact for us, for you in Spain, with continuing austerity of healthcare spending, the power of the funders and the use of generics as cost savings? In London, we have guidelines which are done by the funders as well as our own guidelines, and they are very different. Will HIV treatment be given to all the family doctors and non-EU specialists will be looking after it in 10 years' time? These are all things very close to our homes. So now, concluding, the global situation is political. We can't forget that some countries are at war. We can't forget that there is lots of discrimination that affects health outcomes. We need perhaps a regimen where there's no monitoring except for a baseline CD4 and then viral loads every year. We might get there. An integrase plus TAF plus FTC, maybe we don't need monitoring. If efficacy and safety are similar, then are the only things that differentiate drug regimens whether there's drug interactions or not, especially in the aging population? It's really going to be difficult. And until there is a vaccine or cure, we need TASP and we need PrEP. And finally, I believe there's enough money in the world to stop AIDS. How rich does any single person or any single corporation need to be when they could actually be helping us stopping AIDS tomorrow? Thank you.